Bismillah ar-Rahman ar-Rahim. Good day, everyone. Today we will be talking about preserving residual kidney function in patients on peritoneal dialysis, from traditional strategies to more contemporary approaches in current practice. I'm Dr. Mahmoud Sheikh, nephrology consultant, Warrior Kidney Academy educator. Thanks for joining me, and let's get started. All right, let's talk about something really important in nephrology and residual kidney function, which is defined as basically refers to how much kidney functions a patient still has left, especially in advanced kidney disease or dialysis patients. Now, there isn't one single universal definition. Different studies define it a bit differently, which is why you will hear some variability, but clinically, even a small amount of remaining kidney function matters. For example, if a patient is still making more than 100 millimeters of urine per day or has an estimated GFR of at least 1 millimeters per minute per 1.73 square meters, we consider that clinically meaningful. And the key idea here is residual kidney function is not just present or absent, it's actually a continuous variable, meaning even small differences can have real clinical impact. Even minimal kidney function helps with fluid balance, toxin clearance, and overall outcomes, so preserving it becomes a major role in patients' management. So how do we actually assess residual kidney function? The simplest way is by looking at urine volume. If the patient is still making urine, that's a good sign. You can also measure renal solid clearance like urea and creatinine clearance, which gives more quantitative assessment. And of course, we can use measured or estimated GFR as another indicator. Now, there is an important point. These methods are not exactly interchangeable. Each one reflects a slightly different aspect of kidney physiology. That's why you may see differences depending on how RKF is defined or even measured. And this variability is actually one of the main limitations in the current literature. There is still no perfect standardized way to define or measure residual kidney function. But the main idea is simple. Even small amounts of kidney function matter, and preserving RKF should always be part of your management strategy. So now the big question is why we actually care about residual kidney function. And the short answer is it has a major impact on patients' outcomes. First, residual kidney function helps with solute clearance. And this goes beyond just small molecules like urea. The native kidneys are actually better at clearing things like phosphate and sodium. So even small amounts of kidney function can significantly improve metabolic control. Second, it plays a key role in volume management. Patients with preserved urine output are better able to maintain euvolemia. And interestingly, this is called lower inflammatory burden. So they tend to be more stable overall. Third, and probably most important, is survival. Large studies like CANOSA and NICOSAT have shown that residual kidney function is a strong predictor of survival, and importantly, this benefit is linked to native kidney clearance, not just what dialysis is doing. And finally, it improves quality of life. Patients often have better nutritional status, and they generally report feeling better compared to those with no residual function. So again, even a small amount of kidney function makes a real difference. That's why in clinical practice, we don't just focus on dialysis adequacy, we actively try to preserve residual kidney function as much as possible. All right, now let's talk about something really practical, why patients lose residual kidney function from the start. And the key idea here is that it's multifactorial. It's usually not just one thing, it's the cumulative effects of several ongoing insults to the kidneys. Let's start with hemodynamics as example. Things like hypovolemia, hypotension, even blood pressure variability can all reduce renal perfusion. And when the kidneys are repeatedly underperfused, that accelerates nephron loss over time. Next, nephrotoxins per se play a major role. Calcineurin inhibitors, nonsteroidals, and contrast agents are common culprits. These can directly injure the kidney and speed up the decline in residual function. Also, dialysis itself can also contribute. Excessive ultrafiltration, rapid volume shifts, or even suboptimal dialysis prescriptions can stress the kidneys out. Add to that peritonitis or systemic inflammation, and you get further decline in residual kidney function. In patients with diabetes, glucose-related injury is another key driver. Direct glucotoxicity and osmotic stress can damage renal cells over time. Then we have broader metabolic and vascular factors, oxidative stress, endothelial dysfunction, and even aging, all contribute to progressive decline. And finally, inflammation and infection, things like peritonitis, systemic inflammation, and episodes of AKI can cause sharp drops in residual function. So when you step back, what you see is that RKF loss is really the result of repeated hits. Hemodynamics instability, toxins, inflammations, diet rate stress all adds up over time. The key takeaway is simple. If you want to preserve residual kidney function, you have to actively minimize these insults or these combined multifactorial hits. Now let's zoom in one of the most important drivers of residual kidney function loss, which is hemodynamic factors. This concept goes back to Brecker's intact nephron hypothesis. As nephron numbers decline, the remaining nephrons try to compensate by increasing filtration, what we call hyperfiltration injury. Initially, this helped to maintain overall kidney function, but over time, this adaptive mechanism becomes maladaptive, contributes to further injury. And here is an important point. If we overdo dialysis, especially early on, we may actually blunt this compensatory mechanism and accelerate loss of residual kidney function. Another key driver in this story is the volume depletion. In peritoneal dialysis, for example, high glucose dialysate can drive excessive UF. This leads to repeated, often subtle episodes of hypovolemia. And even if the patient's looks stable, these small drops in volume can reduce renal perfusion. Over time, this predisposes the remaining nephrons to ischemic injury and further insult. So what we are, the main hemodynamic risk we should watch for, excessive UF, for example, and the most important, rapid fluid shifts, intravascular volume depletion, impaired renal autoregulation, and blood pressure variability. And all of these factors share one common pathway: they compromise renal perfusion. So the goal in practice is to maintain stable hemodynamics, avoid excessive fluid removal, minimize rapid shifts, and keep blood pressure as steady as possible, because protecting renal perfusion is one of the most effective ways to preserve residual kidney function. Now let's talk about another major driver of residual kidney function loss, which is inflammation and peritonitis. In patients on peritoneal dialysis, peritonitis is not just local infection, it actually triggers a systemic inflammatory response. This includes cytokine release, oxidative stress, and endothelial dysfunction, and all of these negatively affect renal microcirculation. In fact, each episode of peritonitis has been associated with increased risk of losing urine output, and some data suggest about 3 to 4% increased risk of anuria per episode. So these are not benign events, they have long renal outcomes. Let's break it down. Acutely, inflammation leads to vasodilatation, hypotension. There are also relative hypovolemia. All of these reduce renal perfusion more and more, and that can precipitate ischemic injury to the remaining healthy nephrons. But even beyond acute infection, there are chronic components. Patients are exposed to chronic uremia, glucose-based dialysate, and sometimes less biocompatible solutions. This leads to chronic low-grade inflammation. Over time, that contributes to interstitial fibrosis, progressive decline in residual kidney function remaining. So both acute peritonitis episodes and chronic inflammatory exposure play a role. That's why preventing infections and optimizing dialysis solutions is crucial, because every inflammatory hit to the kidney adds up, and protecting residual kidney function means minimizing both acute and chronic inflammations. In this slide, we focus on a very important concept in peritoneal dialysis, cumulative glucose exposure, which acts as a central mediator affecting a patient outcome. The key idea here is that glucose exposure is not just a byproduct of dialysis, it's actually a measurable and modifiable factor that directly impact both the peritoneal membrane and residual kidney function. Several factors increase cumulative glucose exposure. This includes volume overload, which drives the need for more hypertonic solutions, UF failure, leading to higher glucose prescriptions, high transport status, where patients absorb glucose more rapidly, episodes of peritonitis which impair membrane function, and poor adherence, which can lead to suboptimal dialysis strategies. At the center, we quantify cumulative glucose exposure using practical metrics. This includes grams per day, grams per month, and the number of hypertonic exposures days. Importantly, this is not just theoretical, it's a modifiable and measurable target in clinical practice used nowadays. We can actively track and manage this exposure. Residual kidney function measurements is essential. Volume status monitoring helps guide prescription adjustments. Remote monitoring allows real-time assessment, and emerging AI-based prediction tools may further optimize our care. So increased glucose exposure leads to several negative outcomes. It contributes to peritoneal membrane injury over time. It promotes more and more inflammations. It causes hemodynamic instability, and importantly, it accelerates the decline in the residual kidney function, which is very precious for our patients. The good news is that we can intervene. Strategies include incremental peritoneal dialysis to reduce unnecessary exposure, use of icodextrin instead of glucose-based solution, adoption of more biocompatible solutions, optimization of volume status, and use of diuretics when it's appropriate. So the take-home message is simple but powerful. Cumulative glucose exposure is a central, controllable driver of outcomes in peritoneal dialysis. If we measure it, monitor it, and actively reduce it, we can preserve both the peritoneal membrane and residual kidney function. In this slide, we move from concept to practice. How do we actually quantify glucose exposure in peritoneal dialysis? Because if we cannot measure it, we cannot control it. The proposal is that to standardize glucose exposure using simple reproducible metrics, especially total grams per day and grams per month, combined with the frequency of hypertonic exchange used. The primary metric is daily glucose exposure, expressed in grams per day. It's calculated based on glucose concentration, exchange volume, and dwell time. This gives us practical, precise estimate of how much glucose the patient is exposed to each day. Then we extend this to monthly exposure. Simply multiplying daily glucose by 30 gives a broader picture of cumulative burden over time. This is especially useful for tracking trends and long-term risk. Another critical parameter is hypertonic exposure. We count the number of days where high concentration solutions, typically 2.27% or 3.86% glucose, are used. We also look at the proportion of hypertonic exchange relative to total exchange. This reflects the intensity of osmotic stress on the peritoneal membrane. There is also the concept of absorbed glucose. This is calculated by instilled glucose minus effluent glucose, or sometimes estimated using models. However, this is less practical and has moderate feasibility in routine care. Importantly, most of these metrics, daily, monthly, and hypertonic exposure counting, have high feasibility, meaning that they can be easily implemented in routine clinical practice without complex tools. The most important takeaway here is that prescribed glucose is the primary metric. Absorbed glucose is complementary, mainly useful in research rather than daily practice. So in simple terms, quantify, track, and trend glucose exposure because this transforms glucose from an invisible burden into controllable clinical target to trace and quantify. Now we shift focus to another critical pillar in preserving residual kidney function, nephrotoxic exposures and disease-related factors. These are often underestimated, but they can silently accelerate nephron loss. Let's start with nephrotoxic agents, common offenders like nonsteroidals, analgesics, iodinated contrast media, certain antivirals, or chemotherapeutic agents. These drugs can directly cause tubular injury, reduce renal perfusion more and more. Even a single episode of AKI, especially during hospitalization, can have long-term consequences. What may appear transient can actually trigger irreversible nephron loss and faster decline in kidney profile. That's why prevention is the key. We need systemic avoidance whenever possible, and more importantly, proactive risk assessment before giving contrast or initiating high-risk medications. On the other side, we have the underlying kidney disease itself. Conditions like diabetic kidney disease, glomerulonephritis, persistent proteinuric states continuously drive nephron loss more. The mechanism here is ongoing inflammation and structural damage over time. So even without external insults, the disease process itself is very progressive. Therefore, preserving residual kidney function requires targeted strategies. Anti-proteinuric therapy is essential to reduce intraglomerular pressure and protein-mediated toxicity. Tight glycemic control is very crucial in diabetic patients, and immunosuppression should be used when indicated in immune-mediated disease. The key message is simple: residual kidney function is not lost by chance, it's lost by cumulative hits. Some are iatrogenic like nephrotoxins, others are disease-driven. Our role is to identify both early and intervene aggressively to slow this decline in kidney function. Now we move to the most important part of this talk. What can we actually do to preserve residual kidney function? Because understanding mechanism is important, but applying evidence is what truly changes our outcomes. Preserving residual kidney function is not about one intervention, it's about a combination of targeted evidence-based strategies applied consistently. First, incremental peritoneal dialysis, starting with lower dialysis dose in patients with good residual function helps avoid unnecessary stress on the kidneys. This approach has been associated with lower decline in residual kidney function. Second, the choice of PD modality, tailoring CAPT versus APT based on patient characteristics can influence volume status, hemodynamic stability. The goal is to minimize fluctuation that can harm kidney perfusion over time. Third, using more biocompatible solutions and icodextrin. These reduce glucose exposure and limit peritoneal systemic toxicity, especially important patients requiring higher UF. Fourth, strict blood pressure and volume control. Both hypovolemia and hypervolemia can accelerate loss of residual kidney function. Careful balance is essential to maintain renal perfusion. Fifth, and most importantly, in treatment or management, pharmacological protection. RAS blockade help reduce proteinuria and intraglomerular pressure. SGLT2 inhibitors, emerging evidence suggests potential benefits even in advanced CKD, though data in PD is still evolving. Finally, prevention of peritonitis. Each episode can reduce residual kidney function, cause inflammation, membrane damage, and decline in the function of this membrane. So infection prevention strategies are very critical. The key message is the residual kidney function preservation requires a proactive and multifaceted approach. Small interventions, when combined, create powerful protective effect over time, more than just single modality of management. Now let's focus on one of the most impactful strategies, incremental peritoneal dialysis. This is not just prescription style, it's a philosophy of care aimed at preserving residual kidney function over time. Incremental PD means we individualize dialysis intensity based on patients' residual kidney function. And instead of starting with full dose dialysis, we begin with a less intensive regimen. Then we gradually increase the dose as residual kidney function declines. The rationale is simple but powerful. Lower dialysis intensity early on reduces stress on both the kidney and the peritoneal membrane. It also minimizes cumulative glucose exposure and improves hemodynamic stability over time. Observational studies consistently show that patients on incremental PD tends to have slower decline in residual kidney function. This effect is particularly evident when incremental therapy is started early in the disease course. However, there is an important point to understand. The definition of incremental PD is not uniform across studies. Simply reducing the number of exchanges is not enough. What likely matters more is reducing total glucose exposure. So focusing glucose burden may be more biologically relevant than just counting exchanges. This approach requires close monitoring, as we mentioned in the previous slide, and residual kidney function must be assessed regularly on a regular basis. And dialysis close monitoring, those should be adjusted in a timely manner to avoid underdialysis also. According to ISPD recommendations, incremental PD is acceptable and beneficial when applied carefully, but must only be coupled with structured follow-up and dose escalation when needed. So the key message is start smart, not aggressive. Preserve what patient still has rather than replacing it too early, because once residual function is lost, we cannot get it back again. Now let's make this very practical. How do we actually implement incremental peritoneal dialysis in a structured, safe way? Incremental PD means combining residual kidney function with a reduced dialysis prescription. The goal is to achieve solid and fluid targets while minimizing cumulative glucose exposure. And importantly, this approach includes planned reassessment and timely step-up when needed. Not every patient is suitable. Ideal candidates are those with preserved residual kidney function, as we mentioned. They should have meaningful urine output and stable volume status, no uncontrolled hyperkalemia or acidosis or uremic symptoms, and of course, good adherence is very essential. Close monitoring is the backbone of this strategy. Residual kidney function, urine volume, and labs should be reassessed every 1 to 3 months, and even earlier after events like peritonitis, hospitalization, or sudden clinical changes. We must know when to escalate therapy. Declining residual kidney function or urine output is a key trigger. Failure to achieve adequacy targets is another key. Recurrent hyperkalemia or metabolic acidosis should prompt action. And increasing reliance on hypertonic exchange is a warning sign. The central principle is the balance, minimizing glucose exposure as much as possible, but never at the expense of adequacy or clinical stability of our patients. So incremental PD is not just less dialysis, smart dialysis. It's dynamic, individualized, and requires vigilance. When done correctly, it protects what matters most, residual kidney function. Now we come to a very practical and often debated question. Does the choice of modality APD versus CAPD really matters for preserving residual kidney function? Some studies suggest that APD may be associated with faster decline in residual kidney function. For example, the NICOSAD cohort showed the higher risk of RKF loss with APD, especially in the first year. Another multicenter cohort also reported a higher risk of progression to anuria with APD. However, the story is not that consistent. The PLANS trial didn't find any significant association between modality and RKF decline. In addition, meta-analysis of RCTs have shown no clear difference between APD and CAPD in terms of RKF preservation. So why this confusion from the start? Because modality itself may not be the true driver. These studies are influenced by co-confounders such as patient selection, prescription differences, and clinical practices. The most important point is this: APD and CAPD are simply delivery platforms. They are not biological distinct therapies. What really determines outcomes are modifiable factors: cumulative glucose exposure, volume management, and hemodynamic instability or stability. So instead of focusing on modality alone, we should focus on how we prescribe dialysis. A well-managed APD patient can do better than poorly managed CAPT patient, and vice versa. The question is not APD versus CAPT, as we mentioned. The real question is, are we minimizing harm and preserving physiology? Because that's what ultimately protects residual kidney function. Now we move on a very practical, impactful intervention, the choice of dialysis solution, specifically biocompatible solutions and icodextrin. Traditional glucose-based solutions contain glucose degradation products and have acidic pH. These contribute to peritoneal membrane injury over time, as we mentioned. Biocompatible solutions are designed differently. They have neutral pH, reduced glucose degradation products, and lower cytotoxicity. Clinically, this translates into less oxidative stress and better preservation of the peritoneal membrane. Importantly, randomized trials have shown around 27% better preservation of residual kidney function over time. Icodextrin works through complete different mechanism. It's glucose polymer that provides sustained UF and during long dwells. This allows us to achieve fluid removal without using high glucose concentration. As a result, cumulative glucose exposure is significantly reduced. Clinical trials and meta-analysis have shown improved UF and better preservation of residual kidney function compared to glucose-based solutions. However, there is an important caution here. More UF is not always better. The balance data showed that each 1 liter per day increase in UF, there was an associated 8% worse preservation of residual kidney function. This is likely reflects intravascular volume depletion and reduced renal perfusion. So the goal is not simply to maximize UF, the goal is to optimize fluid balance while protecting renal perfusion. Use biocompatible solutions and icodextrin strategically reduce glucose exposure but avoid overcorrection that leads to hypovolemia. In short, smarter fluids, not stronger fluids, because the way we remove fluids can either protect or harm residual kidney function of our patient. Now we address a cornerstone of preserving residual kidney function, blood pressure, and volume management. This is one of the most modifiable and yet most commonly mismanaged areas in PD. Both extremes are harmful. Persistent hypertension damages the kidney, but excessive blood pressure reduction can reduce renal perfusion. So the goal is balance, not just control. Volume status, as we mentioned, is the main driver of blood pressure in PD patients. Gradual volume control is essential. This includes careful assessment of dry weight, dietary sodium restriction to prevent fluid accumulation. Importantly, many patients are subclinically hypervolemic. Studies suggest nearly half of PD patients may have hidden volume overload. Diuretics can increase urine output, but we must be careful in interpretation. Increased urine volume doesn't necessarily mean preserving kidney function. Some data includes studies from Taiwan suggest faster RKF decline with diuretic use. So diuretics should be used selectively, not as a surrogate for kidney protection. Icodextrin is preferred over hypertonic glucose solution for UF. Provides sustained fluid removal with less glucose exposure. This helps maintain hemodynamic stability and reduce osmotic stress. So in practice, we combine strategies optimizing volume status first, use diuretics cautiously, and favor icodextrin when additional UF is needed. The key message is simple. Protecting residual kidney function is about protecting perfusion. And perfusion depends on suggesting better control and getting volume blood pressure just right, not too high, not too low. Now we move to a cornerstone pharmacological strategies in preserving residual kidney function, RAS blockade. This is one of the few interventions with consistent physiologic and clinical rationale. RAS inhibitors, including S inhibitors, RPs, provide renoprotective effects beyond simple blood pressure lowering effect. They reduce intraglomerular pressure, as we mentioned, decrease proteinuria, and slow progression of glomerulosclerosis. So their benefit is both hemodynamic and structural. Meta-analysis of RCTs have shown that both ACE inhibitors or ARBs provide additional benefit in preserving residual kidney function compared to another antihypertensives. Importantly, these benefits appear to be similar between the two classes. A 2017 meta-analysis further confirmed that RAS blockade is associated with slower decline in residual kidney function, and importantly, without a significant increase in adverse events. In practice, this means RAS inhibition should be considered a core component of blood pressure management in PD patients, especially in those with preserved residual kidney function. Of course, careful monitoring is required. We need to watch for hyperkalemia as a side effect and the change in renal profile. So the role of RAS blockade is not optimal. maybe underestimated, and also it's not optional in most patients. It's foundational unless contraindicated. If we want to preserve residual kidney function, we must reduce intraglomerular stress. And RAS blockade remains one of the most effective ways to do this. Now we move to an evolving and slightly controversial area, the role of SGLT2 inhibitors and other disease-modifying therapies in peritoneal dialysis. The physiological rationale of SGLT2 inhibitors in PD is strong. It improves hemodynamic stability, they reduce intraglomerular pressure, and they modulate inflammatory and metabolic pathways. However, when we look specifically at PD patients, the evidence becomes very limited. Most available data comes from small observational studies. These studies generally show neutral effects, no significant improvement in UF, no consistent benefit in preserving residual kidney function. So at this stage, the use in PD should be considered exploratory rather than the standard of care. Now, the second question is broader. Should therapies started in early CKD stages can be continued after starting PD? The answer is not straightforward. There is uncertainty regarding efficacy in advanced kidney failure, and potential safety concerns must always be considered. Therefore, decisions should be individualized based on the underlying disease for every patient and the level of residual kidney function and the patient comorbidities and the overall treatment goals. Not everything that works in early CKD necessarily works the same way in dialysis. We must critically reassess each therapy in this new physiological context. So the future is promising, but the present requires caution. Use SGLT2 inhibitors thoroughly, and always tailor disease-modifying therapy to the individualized patient. Now we come to a critical and often underestimated factor in preserving residual kidney function, the prevention of peritonitis. Every episode matters because inflammation accelerates loss of both membrane function and residual kidney profile. Peritonitis is not just an infection, it triggers systemic inflammation, it leads to hemodynamic instability, and can cause stepwise decline in residual kidney function. The first and the most important intervention is strict aseptic technique. Every exchange must be done with meticulous attention to sterility. Even small lapses can lead to contamination and infection. Over time, patient may drift from proper technique. That's why regular or retraining is very essential. It reinforces correct practice and identifies gaps early. Prophylactic antibiotics play an important role. They are recommended for procedures and for exercise care according to ISPD guidelines. This significantly reduces infection risk. Aminoglycosides also are still used in empirical therapy for peritonitis. However, they require cautions. Current evidence suggests no major impact on the rate of residual kidney function decline, but the risk of ototoxicity remains a concern. ISPD suggests that N-acetylcysteine may help reduce this risk in selected patients. Preventing peritonitis is one of the most effective ways to preserve residual kidney function. It's not a reactive strategy, it's a proactive one. The best way to treat peritonitis is to prevent it from the start, because once inflammation hits, the damage may already be done. Finally, we address a complex and often overlooked scenario: management after kidney transplant failure and the critical role of treatment adherence. After allograft failure, peritoneal dialysis remains a feasible option. However, the transition needs to be handled carefully. Gradual tapering of immunosuppression is important. This helps reduce inflammation, graft intolerance syndrome, both of which can accelerate residual kidney function loss. In early graft failure, more aggressive strategies like nephrectomy and rapid withdrawal of immunosuppression may be considered, but in later stages, a more conservative approach may be better. For example, continuing low-dose immunosuppression, such as tacrolimus at low dose, may help reduce inflammation. At the same time, we must be cautious. Prolonged immunosuppression increases infection risk, including peritonitis, and that can negatively impact residual kidney function. Now, to a very practical and powerful factors is the adherence. Non-adherent patient is very common. It affects dialysis exchanges, medications, aseptic technique, and dietary restrictions. Poor adherence lead to volume overload, increased risk of peritonitis, and often force us to intensify dialysis prescription. All of these factors contribute to faster decline in residual kidney function. So improving adherence is not optimal in most of patients, but we should work on it to be more optimal, as this strategy is not optional in our PD practice. It's very essential. Patients' education must be continuous, not a one-time event. Regimens should be individualized, simplified whenever possible, and aligned with the patient's lifestyle and capabilities. In many centers, the biggest threat to residual kidney function is not the disease itself, it's the inconsistency in care. So the goal is not just to prescribe the right therapy, it's to ensure that the therapy is actually followed. Because even the best plans fail without adherence. Now we move to a very practical question. How do we actually measure and monitor residual kidney function in daily clinical practice? The simplest method is urine volume. Daily urine about 100 millimeters is generally considered meaningful. However, this is a crude measure. It doesn't reflect solid clearance. It's merely overestimate true residual kidney function. A more accurate and precise approach is renal clearance. This requires time urine collection. We measure urea and creatinine clearance, then take the average to estimate residual kidney function. This method is more reliable and is incorporated into dialysis adequacy calculations. Measure GFR, the most accurate method, using exogenous filtration markers. However, this is rarely feasible in routine practice. So, in reality, most centers rely on serial urine volume clearance measurement. Monitoring should not be on the one-time event. Residual kidney function should be reassessed every 1 to 3 months, and more frequently after events like peritonitis, hospitalization, and major prescription changes. What gets measured gets managed. So regular tracking allows early detection of decline and timely adjustment of therapy. So don't measure on a sole parameter and not assume residual kidney function is stable. Measure it, monitor it, and act on it, because preserving it requires a constant attention. Now we look towards the future, how technology can support preservation of residual kidney function, specifically remote monitoring and AI. Remote monitoring systems connect cyclers and patients' data to cloud-based platforms. This allows real-time tracking of UF volumes, blood pressure, body weight, and treatment adherence. Clinically, this translates into earlier detection of problems, reduced hospitalization, and more timely interventions. However, it's important to be precise. Direct evidence that remote monitoring alone preserves residual kidney function is still limited. AI and machine learning bring an additional layer. These systems can analyze large amounts of longitudinal PD data. They can identify hidden patterns, predict risk of residual kidney function decline, and potentially guide individualized treatment strategies. Early results are promising, but these tools remain largely investigational at this stage. Remote monitoring and AI are an enabling platform. The most important concept is this. They are not standalone treatment. They are enabling platforms to help. They support existing strategies by improving tracking, early detection, decision-making. So instead of replacing clinical judgment, they enhance it. They allow us to intervene earlier, personalize care, and potentially avoid preventable decline. The future of preserving residual kidney function is not only about better therapies, it's about better timing, better data, smarter decisions. This slide brings everything together, what I call the residual kidney function preservation bundle, because in reality, no single intervention is enough. It is a combination that makes the difference. Think of RKFA preservation as a bundle of coordinated actions. Each component targets a different pathway of injury and targets they together create cumulative protecting effect. Volume management, avoid hypovolemia because reduced perfusion can affect accelerate RKF loss. Individualize UF and when possible prefer hypotension over hypertonic glucose solution. Remote monitoring can help track weight, blood pressure, and UF trends, allowing early detection of volume imbalance. Second, the glucose exposure. Use incremental PD strategies, limit hypertonic exchanges, and continuously adjust prescription intensity. Technology can help identify patients with high glucose exposure profiles by compatible solutions. The third one, prefer low GDP neutral pH solutions to reduce membrane toxicity. Tracking treatment patterns help ensure consistent use. Fourth, the peritonitis prevention focus on patient training, aseptic technique, and early treatment. Remote monitoring supports adherence, tracking, and early warning signs. And fifth is to avoid nephrotoxins. Regularly review medications, avoid non-steroidals, contrast when possible. Clinical alerts, medication tracking systems can support this. Finally, continuous RKF monitoring. Use serial urine volume and clearance measurement and integrate trends into clinical decisions. AI and machine learning may help predict decline and guide early intervention. And our close message here is RKF preservation is not a single decision, it is a system of care. And when we apply this bundle consistently, we shift from reactive to proactive nephrology, and that is why we truly protect our patients. Now we can take a step back and critically look at the bigger picture. What do current guidelines tell us, and more importantly, what are they missing? Current IPCD and Kaduki guidelines address many important factors. They emphasize volume management, peritonitis prevention, and avoidance of nephrotoxins, but the issue is that these factors are often presented in isolation as a separate recommendation rather than a part of integrated strategy. They don't fully capture the dynamic and interconnected nature of residual kidney function decline. For example, cumulative glucose exposure, which is central driver, is not consistently defined as a measurable target. Similarly, longitudinal monitoring strategies are not clearly operationalized in routine practice. All this leads to what we call the integration wrap. Emerging tools like remote monitoring and artificial intelligence have the potential to act as unifying infrastructures. We can connect multiple aspects of care into a single coordinated system. However, their role is still underrepresented in formal guidelines, largely because we lack strong perspective, such as using residual kidney function as a primary endpoint. So the challenge is not lack of knowledge, it's lack of integration. We know the individual pieces, but we have not yet fully connected them into a cohesive clinical framework. The future of nephrology will not be defined by new interventions alone. It will be defined by how we integrate what we already know into smarter, more coordinated care. Finally, let's close by looking forward where we are heading and what are the key takeaways from the discussion. First, we need better evidence. Residual kidney function preservation should be defined as a primary endpoint in future trials. We need studies comparing remote monitoring guided care versus standard care with clearly defined RKF outcomes, standardizing glucose metrics. We must standardize how we measure glucose exposure for every single patient, develop practical methods to quantify cumulative glucose from PD prescriptions, and importantly, link these measures directly to RKF decline, independent of volume status or inflammation. And third, we need to rethink incremental PD, more beyond simple counting. So changes focus instead on mechanism, glucose exposure, solid clearance, efficacy, and RKF trajectory. And fourth, AI must be properly validated. External validation in real-world setting is essential. Calibration to local practice and prospective evaluation before adopting it into standard care. The overarching goal is a paradigm shift, moving from episodic isolated decision-making to an integrated, data-driven and RKF-centered approach. One that allows truly individualized, evidence-based peritoneal dialysis care. So the future is not about one breakthrough therapy, it's about integrating multiple strategies into a smarter system of care, because preserving residual kidney function is not a single act, it's cumulative, continuous, and coordinated process. Thank you so much for watching, and feel free to approach us if you have any questions regarding the PD. I try to collect every data I have in this context to preserve residual kidney function in peritoneal dialysis patients. See you in the upcoming lecture. Assalamu alaikum wa rahmatullahi wa barakatuh.